Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Routine Bone Marrow Biopsy Has Little or No Therapeutic Consequence for PET CT Staged Treatment-Naive Hodgkin Lymphoma Patients, by Tarek Christopher El-Galali et al. My name is Bruce Chesson, and I am Deputy Chief of the Division of Hematology Oncology and Head of Hematology at Georgetown University Hospital, the Lombardi Comprehensive Cancer Center in Washington, D.C., USA. My specialty is lymphoma and leukemia. The title of the podcast is Hodgkin Lymphoma, Protecting the Victims of Our Success. And I will start with a quote from the master of the macabre, H.P. Lovecraft. The only saving grace of the present is that it's too damn stupid to question the past very closely. They strapped the fair young maiden to the table as needles painfully pierced the soft flesh between her tender young toes. As if vivisection was not punishment enough for sins unknown, her spleen is stolen, her liver assaulted. She is impaled, her skin repeatedly burned, and her body filled with poison, whilst she is left to await an uncertain fate. Sounds like something from H.P. Lovecraft, does it not? But indeed, that was the ghost of Hodgkin past. Hodgkin lymphoma is considered one of the major success stories of modern oncology. Up to 80% of patients with advanced stage disease and more than 90% with limited disease achieve long-term disease-free survival with standard therapies, and most of those are cured. But the road to cure has been tortuous and torturing. Prior to the availability of CT scans and now PET CT scans, clinical staging included a lymphangiogram, during which needles were inserted between the patient's toes, through which a blue dye was injected to visualize the lymphatic system. The discoloration of the feet was a near-permanent reminder of the procedure. Radiation therapy was the primary therapeutic modality, with chemotherapy reserved for palliation of only the most advanced cases. The most potent of the drugs was nitrogen mustard, a derivative of the poisonous mustard gas from World Wars I and II, which, when used as chemical warfare, would result in skin ulceration, mucositis, blindness, and bone marrow aplasia. When lower doses of radiation failed to cure enough patients, the dose was increased to the point where patients suffered from horrendous toxicity and subsequently a high frequency of acute leukemia, despite being cured of their disease. Because of inadequate imaging techniques, all but those without obviously advanced disease were subjected to staging laparotomy with splenectomy, the latter resulting in a lifelong risk of fatal sepsis from encapsulated organisms. The first curative chemotherapy regimen included meclorethamine mustard, vincristine, prednisone, and procarbazine, or MOP, which was also associated with acute toxicities of profound nausea and vomiting in the pre-ondansetron era, a substantial risk of leukemia and solid tumors, as well as almost universal sterility. Despite these aggressive measures, many patients still relapsed, whilst others succumbed to the long-term sequelae of therapy. In few instances in oncology has progress been so methodical. Total nodal irradiation went subtotal, extended field, and then involved field. Randomized trials demonstrated that regimens such as adriamycin, bleomycin, vinblastine, and dacarbazine, or ABVD, were more effective than MOP and without the secondary cancers and infertility. Recently, the German Hodgkin Lymphoma Study Group demonstrated that, for limited disease, 2 cycles of ABVD plus only 20 gray of radiation therapy may be adequate for 93% freedom from treatment failure in patients with early-stage disease. Data suggest comparable efficacy for involved nodal radiation therapy, with a hopeful reduction in late effects. Recently, the availability of the exquisitely active brentuximab vedotin, a monoclonal antibody drug conjugate, has generated hope that we may be able to reduce the amount of chemotherapy further, even in the frontline setting. And this possibility is the subject of planned clinical trials. Lymphangiograms have been supplanted by CT scans and gallium scans by CT PET scans, negating the need for unnecessary and hazardous surgical exploration. Even the chest X-ray, one of the holdovers from the Ann Arbor staging system, is no longer needed because of the increased sensitivity of CT scans. For decades, patients have been treated with an arbitrary number of 6 to 8 cycles of chemotherapy. Instead, the high negative predictive value of the CT PET is being evaluated as a predictive marker in risk-adapted clinical trials in an attempt to improve outcome by altering therapy in poor-risk patients and reducing the amount of therapy in those with lower-risk disease. Yet there is one last bit of torture that has persisted, the dreaded bone marrow biopsy. To adequately stage patients to deliver optimal therapy, assessment for potential bone marrow involvement has been considered mandatory for nearly all patients. The trephine is feared by patients who at one time were subjected to bilateral sampling, yet more recently to only a one-sided procedure. Over the years, a number of smaller studies and a meta-analysis have suggested that in Hodgkin lymphoma, the use of PET-CT may obviate the need for a bone marrow biopsy in initial staging of Hodgkin lymphoma. Nevertheless, the procedure may still be needed for non-Hodgkin lymphoma, where there is a risk of involvement of the bone marrow with a histology discordant from the diagnostic bone marrow biopsy. However, such is not the case in Hodgkin lymphoma. A finding consistent amongst these studies is that no patients with advanced stage disease have bone marrow involvement without other evidence of being stage 4 or in the absence of disease-related symptoms. The Ann Arbor staging system was originally developed to guide the direction and dose for the radiation oncologist. Now that we have moved from exclusively radiation therapy towards mostly systemic therapy or combined modality treatment, the need for a bone marrow is further reduced. The paper in the current issue of Journal of Clinical Oncology by Galali et al. Provides perhaps the most convincing evidence that we can now spare all patients the pain and expense of the bone marrow biopsy. In this retrospective analysis of 454 patients with Hodgkin lymphoma, there were no patients whose therapy was altered on the basis of a bone marrow biopsy. PET-CT identified focal lesions in 18%, yet the bone marrow biopsy was positive in only 6%. There were no patients with PET-CT stage 1 or 2 disease with a positive bone marrow. Indeed, in only 4 patients was the bone marrow positive while the PET-CT was negative. Nevertheless, while the bone marrow upstaged 5 patients, it was from stage 3 to 4, with no alteration in treatment strategy. Indeed, the negative predictive value of the PET-CT for the bone marrow was 99%. Many current and all future studies will no longer need to include either a routine chest radiograph or a bone marrow biopsy. And these changes in practice will be codified in the upcoming modification of the staging and response criteria expected to be presented at the 17th International Conference on Malignant Lymphoma in Lugano, Switzerland, June 2013. We have succeeded in curing the vast majority of patients with Hodgkin lymphoma. The next goal is to minimize the torture whilst rescuing those in distress. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.